Hello, the term dry eye seems self-explanatory. It gets bandied around by patients and optometrists as if it's all terribly obvious. In reality, it's an extremely inadequate descriptor of the ocular complexities a clinician must unravel. So in this talk, I'm going to break it down into parts. First, I will explain how the ocular surface remains healthy and comfortable. In part two, I will critique the current benchmark literature and explain why we at ARENS prefer the term ocular surface disease to dry eye. And finally, in part three, I'll explain the diagnostic sieving routine we follow when investigating the multiple causes of ocular irritation. You can fast forward through any parts you like, but out of courtesy, I feel everyone deserves a fuller explanation of this surprisingly confused area of clinical practice. So for successful management of this entity people call dry eye, empathy and understanding on the part of the clinician and time to educate the patient is crucially important. Hence this presentation, to be honest. Dry eye is often a chronic condition with no permanent cure, and best outcomes are achieved when the patient understands the real problem. Recommended interventions then make sense and compliance improves. Any management plan should always be an agreed one between patient and clinician for it to be successful. So part one, how does the ocular surface work normally? The tear layer is the first surface light hits as it's coming into your eye, and if the tear layer is a bit wobbly for whatever reason, your vision is going to vary. So it's important to maintain stability. The tears are actually made up of three layers. The closest to the epithelial layer is the mucus layer. I often say it helps stick everything on, but it also isolates microorganisms, stopping invasion. The second layer is the aqueous or water layer. This is a source of nutrition for the cornea because it doesn't have a blood supply. It also dilutes toxins and flushes them away. And at the very front, we have this very thin but critically important lipid, that's oil layer. It stops the tears evaporating and holds them up. So even if there's a good tear volume, if the lipid layer is poor, the tears will evaporate far too quickly and actually just drain from the eye. Now the lipid layer comes from meibomian glands in the upper and lower lids. If these become blocked or infected, it causes a condition called blepharitis, which I'll show you later, and this is critically important in ocular comfort. So let's look at each layer individually. The mucus layer comes from goblet cells, which are distributed in the conjunctiva across the white of your eye and underneath the lids. So anything damaging the conjunctiva is obviously going to disrupt the mucus production and therefore tear quality. Remember, the thin lipid layer is produced by the meibomian glands in the upper and lower lids. So using a special scan, the very top image shows full and healthy glands, whereas the lower image, the glands are dropping out and they're not producing enough oil. The image at the very bottom shows the openings of the meibomian glands as they come onto your eye. In this example, the openings look thick and blocked. This is posterior blepharitis, which would clearly have an impact on tear quality. Finally, the aqueous middle layer of the tears comes from the lacrimal gland above the eye. Ideally, the tears flow across the ocular surface, keeping it moist and comfortable, and then pool along the lower lid. Now, this recording shows how the lids manage tear distribution and clearance. The upper lid does all the blinking. It goes up and down. The lower lid does not go up and down. It goes left and right and pumps the pooled tears along the lower lid towards the drainage channel and into the nose. Now let me show you that again. As you can see, the upper lid is doing all the blinking. The lower lid is the pump directing the tears into the nose. Now while we're on the subject of blinks, the resting blink rate is about 16 times a minute, but drops to 4 a minute during concentrated visual tasks such as PC use. This represents a huge drop in refresh rate, resulting in much more evaporative stress from the surface of the eye. And our eyes actually have extremely complex nerve supplies with feedback loops controlling tear production, tear volume, blink rates, and responses to trauma. We all know if we get a bit of grit in our eyes, they immediately water because they're trying to flush out the irritation. Then there are hormonal roles, especially estrogen and androgen. These are important in meibomian gland health. And obviously, a hormonal imbalance will disrupt meibomian gland and tear quality. And of course, there are the normal environmental evaporative stresses all our eyes are subjected to in a modern world. Stresses capable of simply overwhelming an otherwise normal system. On that subject, due to environmental conditions and despite having perfectly healthy eyes, many of us will experience low-grade ocular irritation. The two classic scenarios would be driving and sustained desktop use. As well as our blink rates dropping, our eyes are also wide open, exposing a greater area for evaporative drag. Further, the environment is probably quite dry with heaters or air conditioning. So in the office, think about improving humidity, drink lots of water, hydrate from inside out. And work stresses and commitments aside, try to think about regular short breaks. The 20-20-20 rule. Every 20 minutes, look at something more than 20 feet away for 20 seconds. Now, logically, in this office scenario, the symptoms will be worse in the afternoon. And non-preserved drops can be of help here. So dysfunction or overwhelming of any of the ocular features described in part 1 will cause ocular irritation, often simplistically termed dry eye by busy clinicians. But the author Dupp said in 2007, precise descriptive words become shorthand for complex concepts. The wrong words are likely to confound rather than enlighten. And I would say the term dry eye does just that. I would like to present a case demonstrating why, in my opinion, the term dry eye is at the very least misleading, at worst engenders mismanagement. At our first meeting, this lady reported being diagnosed previously with dry eye and had been prescribed Viscotears. This did not ring alarm bells initially, as many people mentioned dry eye, and she was not describing ocular irritation, but simply blur. Routine slit lamp examination, however, revealed a lot more. And there's a picture of a slit lamp just in case anyone doesn't know what they look like. Now, fluorescein dye stains damaged cells. As you can see, the front of her eye is just a massive staining, so it's a very uncomfortable eye. And this prompted the question, how often are you instilling Viscotears? And she then admitted the dryness was becoming so bad she was putting the Viscotears up to 15 times a day. And obviously, as far as she was concerned, this was the solution to the problem of dryness. But Viscotears is preserved, and preservatives are toxic. And the more you put in, the greater the toxic effect. While preservatives kill bacteria, they also damage our own tissue, hence the toxic result. One can imagine at some point in the past, she mentioned to a clinician her eyes felt gritty, getting the response, oh, you must have a dry eye. Viscotears was prescribed, commencing the escalating process. So what we're looking at is not a dry eye at all. It's a toxic reaction to preservatives. And the management was to stop the Viscotears after thoroughly explaining the situation and cause. And this is what her eyes looked like 4 or 5 weeks after we'd ceased the Viscotears. So the take-home points. 1. Patients deserve a proper diagnosis and a proper explanation of what the heck is happening on their eyes. This patient, who is now in her 90s, totally changed the way I define, for my clinical practice, dry eye. We never use preserved drops. They are toxic and you don't want toxins in your eye. The Dry Eye Workshop, DEWS, has generally been considered the benchmark text on dry eye since 2007, but as a clinician dealing with patients with ocular discomfort on a daily basis, I've never found DEWS terribly helpful. While it represents a huge commitment from world-leading academics, it is an academic exercise via reviewing and collating evidence from current literature. No clinicians were involved. Once analysed, DEWS then defined the entity they call dry eye. They say, Dry eye is a multifactorial symptomatic disease characterized by a loss of homeostasis of the tear film and/or ocular surface, in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities are etiological factors. Whew. Okay, now that's a very intricate definition, but apart from saying it's a multifactorial symptomatic disease, I do not think it tells us what dry eye actually is. Good definitions should be an asset to both patient and clinician. They guide clinical decisions and let us have meaningful conversations, and I just don't think the Jews definition fills the bill. This one from the Association of Optometrists simply states, people with dry eye either don't make enough tears or the tears they have are of poor quality. And this is certainly easier to relate to a patient. As a point for later, tear-deficient dry eye, while relatively rare, carries significant consequences, and I feel the clear inclusion in the AOP definition is actually relevant. So back to Jews. Their primary goal has always been to allow rapid diagnosis of dry eye. The 3-point diagnostic algorithm is certainly quick, but is it effective? Step 1, complete the 6-point questionnaire, which they suggest could be administered in the waiting room before the clinician even sees the patient. And to me, this is totally ludicrous, diminishes the role of the clinician and the complexities of investigating ocular surface diseases. Number 2, though, they say measure non-invasive tear breakup time. Jews stress non-invasive tests must be done before instilling dyes. This is logical. Tamper with what you're observing will change what you're observing. However, the Jews academics do not consider or include the huge array of non-invasive tests a good clinician has already done prior to this very restricted clinical goal. I will demonstrate this later. And step 3, usually involving dyes, is assess ocular surface damage. At this point, according to Jews, dry eye has officially been diagnosed. Yet Jews state categorically dry eye is simply a subset of ocular surface disease, meaning this very targeted outcome is buried within a complex clinical jigsaw. So let me reveal the entire Jews flow diagram. Before all else, they say, clinicians must consider differential diagnosis, which they suggest could mimic dry eye. In my opinion, these are not mimics, but separate and important alternate pathologies. Jews do give 6 little questions to aid technicians, but the clinical responsibility is encapsulated in the statement, detailed anterior eye examination is required to confirm differential diagnosis. This would undoubtedly involve a slit lamp examination incorporating invasive tests long before we get to the simplistic diagnostic algorithm. Jews actually expend multiple pages of text describing the many things dry eye isn't. And in their figure 2, they state it gives an overview of the common differential diagnoses. And remember though, Jews consider dry eye to be simply a subset of ocular surface disease. So we really have a hunt on our hands. The 6 little questions is hardly going to cut it. Anyway, once we're past differential diagnosis, we meet risk factors with the vaguely described certain medications. In the main Jews text, drug families demonstrating association with dry eye are discussed, but these are generic and clinicians often need far more detail. Clinicians have to be familiar with many common meds, a familiarity only possible with constant practice with every patient. Only then can unusual drugs and symptoms be red flagged. I will demonstrate this later. Finally, we can complete the official Jews diagnostic algorithm. But now, apart from being able to tell the patient they officially have dry eyes, I'm not sure it helps. This is because after diagnosis, we still have to identify what Jews call drivers causing the tear state of affairs. And of all the drivers, I would highlight this easily missed one at the bottom: systemic conditions. It's another clinical minefield belonging way earlier as part of a clinician's full workup. So despite selling dry eye as an easily diagnosed, self-contained entity, Dews repeatedly use the terms drivers, causal mechanisms, and triggers to describe the real causes of dry eye. So dry eye is clearly an outcome. It is the causal mechanisms a clinician must diagnose if they are to successfully manage the problem. And to repeat, Dews actually state this important principle. They say, hence, dry eye disease remains a specific symptomatic subset of ocular surface disease, and differential diagnosis is important. A simple statement representing a bucket load of work. To me, the entire Dews exercise is tail wagging the dog. Rather than fixating on a very narrow clinical entity with many drivers called dry eye, clinicians have to investigate the entirety of ocular surface disease. It is not okay to simply say, you have a dry eye. So finally, part 3. How do we systematically investigate ocular surface disease and dry eye? Let's get to the nitty-gritty. Diagnostic sieving is a systematic approach used in medicine to aid diagnosis. It helps ensure all possibilities are considered time efficiently without having to learn by rote and wade through the myriad of potential conditions and symptoms. Anatomical sieving ensures we examine all ocular structures by moving systematically from front to back. Subtle signs are less likely to be missed. And sieving doesn't actually start at the slit lamp. It doesn't even start in the clinic room. It actually starts in reception. You're watching patients. Is the patient closing an eye? If there's ocular or lid redness, is it apparent in one or both eyes? Do they seem light sensitive? Are they wearing dark glasses? And especially with the elderly, how do they walk? Are there any bruises, joint swelling, dermatitis, rosacea, Bell's palsy? Do they actually look well? While not considered by Dews, these are all non-invasive tests and aid the overall assessment of a patient, a process not to be underestimated. Once in the clinic room, sieving continues, and this must incorporate an exhaustive case history involving a thorough assessment of general health and medications, vital when assessing someone reporting dry eye symptoms. The Dews flow diagram highlights certain drugs as a risk factor and systemic conditions as a driver, but these simple statements belie the complexity of the task at hand. And optometrists are told to take drug litanies, but they're not really taught to do it very effectively. And this setup is not uncommon. You see a list of drugs in no particular order lumped in one section and general health listed elsewhere. And also some drugs are used for multiple health issues. So without knowing why a drug was prescribed, we are missing potentially important patient information. And looking at this list of drugs and conditions, even an experienced clinician would be challenged identifying potential red flag drugs or illnesses possibly implicated in the patient's presenting symptoms. Now, this is the same list reordered logically with conditions and allows a rapid understanding of the patient, both their medical conditions and associated medications. So, on to our specific patient. His primary presenting symptoms were dry mouth primarily and gritty eyes. Now, this question is asked in Dews differential diagnosis, but the question is specifically targeting Sjogren's. And clinicians must be aware other illnesses or drugs can also be implicated, as in this case. The patient suggested the symptoms evolved over the previous 6 months and felt it started at about the time he was prescribed solifenacin. This observation is clearly a red flag and warranted investigation. So for solifenacin, Electronic Medicines Compendium report dry mouth, dry eyes, nasal dryness, dry throat and dry skin as very likely. So for sure, this drug dries people out. So without doing any clinical tests at all, we have a strong contender for the dry eye symptoms. Now clearly, As thorough clinicians, further tests probably targeting tear deficiency will be done, but the presentation has been effectively sieved. So here are examples where non-invasive, unobtrusive observations, particularly of the lids and without a slit lamp, clinch the diagnosis and trigger targeted questions. A patient may describe intermittent dry eye during the case history, and perhaps out of the corner of your eye, the patient is noted doing a heavy blink and suddenly the lower lid just turns in. This is involutional entropion, and it will quickly pop out. And if you're not really observant, you'll miss this. The probable cause of the patient's reason for seeking your advice has just been identified. Clearly, you need to do more tests to assess everything, but basically your diagnosis is made and the outcome would be referral for lid surgery. The reverse of entropion is ectropion. The lid is lax and turns out, and this is very common. Many patients report symptoms of dryness, but the eyes will also water because the lid tear clearance mechanism is compromised. Again, referral for surgery is appropriate. Now, both these patients would pass a DEWS 3 diagnosis algorithm for dry eye. And I ask you, would that really be helpful? This lady actually booked in for a dry eye assessment. She had already been diagnosed with dry eye and blepharitis, been given a myriad of drops and ointments by different people, but without a structured plan and without any success. And take my word for it, the appearance of those lids does not suggest dry eye. The essential case history, you need the backstory. She has eczema, asthma, severe allergic conjunctivitis. These are all allergic conditions, and she has been prescribed a very strong antihistamine by her GP. And the primary symptoms itch. With her backstory coupled with the eyelid appearance, I made the diagnosis of allergic dermatitis pretty much before I did any other clinical tests. Slit lamp identified ocular signs supporting my diagnosis. I prescribed a steroid cream for the lids, not the eyes, and it would resolve in 24 hours. I really wish all dry eye was that simple. As we know from the past few cases, and also part 1 of this talk, the lids are vital to maintain tear distribution and quality. So they have a lot to answer for when it comes to symptoms of dry eye and ocular irritation. An important lid problem is blepharitis, and I do think when many optometrists talk about dry eye treatments, they are talking about blepharitis, so it's worth expanding. But even blepharitis represents a spectrum of issues which must be investigated to target treatment appropriately. First, anterior blepharitis. This is on the lash line. A lid cleaning regime is important, and this is ours. But the need to cherry pick for individual presentations still exists. For anterior bleph, heat bags are recommended, but self-expression is not necessary. That would be more appropriate for posterior blepharitis. Lid cleansers are helpful. We recommend gels. They're easy to use, and environmentally there are no non-compostable cloths, and the cans can be recycled. The College of Optometrists also recommend chloramphenicol ointment, which is an antibiotic, and sterilize the lids of bacteria which produce the toxins causing the effect on the lids. And some patients also like the BlephX, which scrubs the lids clean. Posterior blepharitis is also called meibomian gland dysfunction because of the actual glands affected. When you squeeze them, the expressed lipid should be clear, but with posterior bleph, the lipid will be thick, sometimes like squeezing toothpaste. In this case, the full hygiene routine is necessary. Heat the glands with an eye bag to get the oils beyond the melting point. Self-express them to get the oils out. Then lightly wash your lids in warm water. It doesn't have to be boiled, so the lipid doesn't recongeal. Lid cleaning foam is the final step to ensure the bacterial load, primary cause of the problem, is controlled. Demodex blepharitis is different. It's not caused by bacteria. It produces extremely greasy looking eyelashes, and treatment has to be customized to target the Demodex. We especially need to keep the lids really clean. Expression again is not necessary, and the lid wipes recommended have tea tree oil incorporated specifically for Demodex. Posterior blepharitis can become severe and even ulcerative. This clearly needs to be addressed as meibomian gland dropout is likely. Toxins along the lid margins can also instigate a corneal inflammatory response. In this case, we would prescribe a tetracycline drug such as doxycycline. These are the go-to drugs for blepharitis as they have both antibiotic and anti-inflammatory effects. If the cornea is involved, a topical steroid could also be added to the mix. Meibomian glands can also become infected, becoming styes. Now, styes can self-resolve, but if multiple and recurrent, we will prescribe a different systemic antibiotic. In this case, we will prescribe coamoxiclav, after confirming the patient is not allergic to penicillins, of course. Styes and ulcerative lids cannot be treated with standard blepharitis management. They are acute states and styes are quite painful. But these conditions will represent acute presentations of an underlying posterior or anterior blepharitis. So once the acute stye is eliminated, a stringent hygiene regime should be instigated. While beyond blepharitis, cicatrized lids are scarred, usually older, and there is significant gland dropout. It isn't helpful calling it bleph and suggesting lid hygiene would help. It would achieve nothing as the lids have nothing left to give. Advice is important. Lubricants will help keep the eye comfortable, and this is a classic scenario where liposomal sprays such as Optase or iLogic can really help. Sprayed on closed lids, which may seem odd, as the patient blinks, tiny droplets of lipid fall down onto the tear layer, re-establishing the lipid protection. So especially with gland dropout, they make sense, and when prescribed properly, people get real benefit. And finally, chalazion. If a gland becomes chronically obstructed, our own body defences seal it off in a granuloma, so preventing further tissue damage. And in the eye, we call this a chalazion. They are no longer infected and are non-painful, but they are not easily removed. Conservatively, hot compresses and expression can be tried, but usually the patient needs to be referred to have it excised. And so beyond the lids and onto the tears, tear-deficient dry eye, which is, in my opinion, true dry eye, will universally have an underlying, often quite serious general health cause. A complete medical workup with health assessments and medications, past and present, is essential. Now, this is a flow diagram I actually adapted from the original DEWS document of 2007. Later editions incorporated tear deficiency into the overall spectrum. However, in my opinion, the medical implications of tear deficiency are too important and deserve more targeted attention to emphasize the essential co-management. It is not enough to simply start treating the tear deficiency. So if a systemic drug is suspected to be the culprit, advising the patient and treating the tear deficiency would be necessary, as we would definitely not stop the medication. This completed drug health assessment to the right identified tetrusitol as a red flag. Electronic Medicines Compendium was again referred to and identified as very common or common dry mouth, dry eyes, and dry skin. In this situation, it would be courteous to liaise with the GP, who would probably put the prescribed lubricants on repeat. Autoimmune diseases, primarily rheumatoid arthritis and Sjogren's, definitely cause tear deficiency. With Sjogren's, our own immune system attacks secretory glands throughout the body, but primarily the lacrimal glands, giving a dry eye, and salivary glands resulting in a dry mouth. These must be co-managed with ophthalmology and rheumatology. While we can strongly suspect Sjogren's via our clinical assessments, the gold standard test is salivary gland biopsy. And in severe cases, the clinician will throw everything at these people. Above and beyond marinating the ocular surface with high-quality, non-preserved lubricants, the patient may be prescribed the mucolytic eye lube, to break up mucus when, due to lack of water layer, it adheres to the cornea and is very painful. Steroids to control the chronic inflammation induced, as well as the immunosuppressant cyclosporin. Because the causes of tear deficiency are systemic conditions, logic tells us the clinical observation should be bilateral. And in the majority of cases, this is true. However, there are a couple of extremely rare situations resulting in unilateral lacrimal gland dropout. One would be lacrimal gland scarring, in which case there would be a clear history of trauma. The other would be lacrimal gland carcinoma. Now, in my entire 40-year career, I've never come across a unilateral tear-deficient dry eye. But as Lou Catania said, it isn't rare if it's in your chair, and clinicians must be alert to the possibility. And now the cornea and conjunctiva. Most delicate mucous membranes in the body are protected from the drying effects of external environment, in the gut for instance. Not so the epithelium of the cornea and conjunctiva. These surfaces have to remain bathed in a tear layer. If the corneal conjunctival surfaces are raised due to inflammation, degeneration, infection or trauma, including surgical trauma, the surfaces will no longer be bathed in tears and become dry. Let's cherry pick a couple. Conjunctivochalasis is simply loose conjunctiva. The folds are exposed, but also drape over the lower lid, disrupting tear clearance. Pterygium result from chronic exposure to UV light, wind and dust. They're raised, and especially in dry environments can become inflamed and irritable, the bottom left being a good example. Surgical filtering blebs post-glaucoma surgery are necessarily raised with potential irritation. And even routine ocular surgery such as cataract extraction can impact ocular comfort. The lids have to be clamped open, and of course our tissues don't spring back as well as we get older. Post-surgery, the eyes may feel dry as the tear lid refresh processes have been compromised, at least temporarily. Most of these are managed with lubricants, but the patient must be aware they are not a cure. They simply relieve the symptoms. Now this is different. It's epithelial basement membrane dystrophy and needs a more specific management. The scallop pattern is created as the fluorescein dye pools around epithelial irregularities. And during sleep, the epithelium always swells slightly, and if not bound well to the underlying tissue, the shear forces of the lid's opening when you first wake up effectively tears the epithelium. It is a very sharp pain. Specifically on waking, it does resolve quite quickly. And this is where thick ointments are prescribed. They are instilled prior to bed to protect the cornea and relieve the shear forces on waking. Hycosane night would also be prescribed for a thing called lagophthalmos. This is where the lids remain ever so slightly open when sleeping, allowing surface drying and discomfort on waking. And so my final case, entitled "Sometimes Presentations Can Be Very Confusing." This lady presented for simple routine eyelash removal. She has long had what she called dry eye, had been prescribed a variety of lubricants, as you can see. She also has ingrowing eyelashes regularly removed, as well as previous cryoablation to prevent lash growth. So a quick eyelash removal, you'd think. However, a full anterior eye assessment revealed nothing. Lids, tears, cornea, all perfect. The severe pain could not be explained, and I don't think she believed me when I told her I could find nothing. And to re-stress how case histories cannot be squeezed into the initial 5 minutes, unexpected observations will trigger specific investigations or questions, as in this case. The symptoms were very severe and way out of proportion to anything visible on her eyes. Her general health history included a rare disorder called erythromelalgia, and I decided to investigate. It is characterized by intense burning pain, primarily on hands and feet, and causes dysfunction in pain-sensing nerves. My investigative test was to instill the topical anesthetic oxybuprocaine, which should have given rapid relief if the pain was surface damage in origin. It did not relieve the pain at all, suggesting it was neuropathic and possibly related to a condition. Once this possibility was voiced, she did admit, in hindsight, no previous management had been beneficial either. So I reported my suspicions to her GP, recommending the information be conveyed to a consultant dermatologist, and suggested systemic pain management. So thank you very much for sticking with it right through, even that last one. As medical optometrists, I believe there is a lot we can do, but it does take time, and patient and clinician must work together for the best outcome. Thanks.